Hi everyone, this is Dr. Stefan. In this video, I'd like to discuss about lung function testing, which is something that many patients really undergo, things like spirometry, gas transfer, things like that. So in this video, I'm going to try to make it as simple as possible for you to understand, but at the same time, I will be very thorough. And I'll try to go over what some examples would be of abnormal and normal spirometry and why it's sometimes difficult to just simply give you an answer if you receive a report. And hopefully this will be very helpful for you. I think even though I will try to speak in terms that anyone can understand, I'm pretty sure that even some of my medical colleagues might find this helpful, especially the examples at the end. That being said, let me just start with this document and I'll run you through this material that I've prepared just to go over what is lung function testing, what types of tests can be done, what do the results mean towards the end, and I will, of course, focus on spirometry because this is the most common lung function testing that's being done and the one that most patients will be familiar with. So I'm just going to go down. What is lung function testing? So let's start with that. So basically, when we're testing the lungs, we're trying to find out how they work. We're trying to find out if our lungs are operating at maximum capacity, at the normal capacity, less than what we would expect. And these things can be inferred from how much air we move in and out of the lungs. But that's not the only thing. We can also measure how oxygen is being absorbed in the body, how it's being transported through the body, how much exercise we can actually do. All of these things are functions of the lung and the cardiovascular system as well. But the lungs play a big role in providing the body and the cardiovascular system with enough oxygen in order to be able to carry out its duties. So for example, if we are trying to lift heavy weights, of course our muscles will use a lot of oxygen and our lungs need to be able to provide that. That being said, let me just move on to what types of tests we can do to check that, because I think that's really important. So lung function testing is extremely complex. We can do a lot of tests. I've put some dots at the bottom here because actually there are many others. But these are some of the more common ones that you might come across. So peak expiratory flow, I've done some videos on this one. It's a test that's commonly used in asthma. It's something very simple where basically patients just blow into a tube quickly and just, it's like a burst. We just blow like that. And that's a measure mostly of how quickly we can move air in and out of the lungs. That's helpful in some situations, normally in asthma, but not many other situations may warrant this test. A spirometry, however, is something that I will focus on extensively in this video if you have the patience to watch toward the end with the examples and everything else, because it's a fairly comprehensive test in the hands of a specialist who knows what to look out for and integrates the results of spirometry with the rest of the medical information. In that case, it can actually be a very helpful tool, and you'll see towards the end of the video. Gas transfer is something added on top of the spirometry. We're trying to measure how quickly your body is absorbing gases from the environment. How quickly is your body taking up oxygen from the environment? That cannot be measured directly, but it's done through the use of carbon monoxide, which diffuses through the alveolar membrane, through the structures of the lung very quickly. So that's how it's being done. Oxygen saturation can be measured with a pulse oximeter. So one of these little devices that you clip onto your finger, and it measures the saturation of oxygen in the blood. And that can, sometimes give you some information about how your lungs are working, depending on the condition. But it depends, as you can see, you would choose one of these tests depending on the condition you are trying to monitor or trying to diagnose. Then there's various types of exercise testing, including simple walking tests, or walking with a pulse oximeter, or seeing how far you can walk, or to the point where you're getting on an exercise bike or a treadmill and you have a mask connected to you and you're doing a cardiopulmonary exercise test. So that can again be something that you may have seen online. For example, when you see athletes who are training, you will see them wearing these masks and running on a treadmill. That's cardiopulmonary exercise testing for you. Arterial blood gases. Sometimes we need to measure the concentration of oxygen and carbon dioxide in the actual blood. So in order to measure the most accurate sort of concentrations, we need to measure the blood that basically comes from the lungs, carrying oxygen and going to the rest of the tissues. And that's arterial blood. It's not in your vein, it's in the arteries, the blood tubes that carry the oxygen basically from the lungs through the heart and out towards the rest of the body. So that's something that can be measured through a near lobe sort of needle puncture or an arterial puncture. And it's not the most comfortable test, but it is necessary in circumstances, especially when people are really unwell, in order to determine if their lungs are operating properly and that they can handle the situation, basically. Plethysmography is a more complex form of spirometry, I would say. It works in a different way. You have to get inside a sort of a box that is sealed, and then you breathe and do a sort of a spirometry maneuver in that box, and it measures basically based on the variations in the volume inside the box and inside your lungs. It sort of works out how much air is left after you've emptied your lungs completely, because you can never get all the air out of your lungs. There will always be a little bit left at the end. So plethysmography is a more complex test that can measure that. And then oscillometry is again something that works with the help of sound waves that are being sort of shot down your airway, and there's some sort of resistance to that shock wave. And so all kinds of things can be done to measure lung function. People have been extremely creative in this space. It's a fascinating field. There are many physiologists who actually do this for a living. So shout out to the physiologists out there, because they do an incredibly fantastic job at actually getting these tests done and interpreting them. And they help us a lot. Depending on the country in the world where you may be in, some of these tests may be done by physicians. They may be done by nurses, physiologists. It's all a little bit different, but actually it all works out to be the same, because most of these tests are actually standardized. Now, that being said, let's move on and focus a little bit on spirometry, because this is what I'd like to talk about in this video. It's the most common test. You may have seen this sort of image before. The patient has a little bit of a nose clip, something on their nose to block the flow of air through the nostrils. They bite onto a little mouthpiece, like in this image, and a technician or a physician or a nurse or a physiologist or someone else is instructing them how to breathe according to the specifications of the machine in front of them, because this is the spirometer. It's a machine that records airflow through this mouthpiece. That's all it does. But it has to be done, this maneuver has to be done in a specific way in order to get accurate results, and results that we can actually interpret, because we are trying to measure some very specific things, and I'll show you in a minute. And I'll also give you some examples, like I said, towards the end, of what's normal, what's abnormal, and why it's a little bit tricky sometimes. So stick around. Now, what does spirometry do? It's a very simple test. So many people are worried. I've got this a lot from patients. They've asked me, they think that spirometry, many people actually think that spirometry is a very complicated test, and all the numbers that you get, because the machine prints out a lot of numbers, right? So people are thinking that, all these numbers mean a lot of things. It depends. So you can imagine, I'll just give you a quick example. If you are trying to measure a volume of air, so you're trying to blow through that mouthpiece. Of course, if you're not doing the test correctly, you're not blowing all the air out, you will get different results. If you blow like this, you'll get a result. If you go like this, you'll get more. So it all depends. If you're not biting correctly on the mouthpiece, and your mouth is a little bit open on the side, some air blows to the side of the machine, that won't be measured. So those values are just measurements. So it's important to do spirometry in a standardized way. So mostly it's done during a forced breathing maneuver, because that leads to most reproducible results and correct results. And I'll explain in a second how we do that, but basically simple, but needs to be standardized. That's why we have technicians who help people do that. There is, however, nowadays a move towards home spirometry. So because these devices are becoming more common, they can be connected to smartphones, to other, the Internet of Things, really. You could connect them to the Internet, and your doctor may actually be able to see results in real time. And there's been an explosion, actually, especially in the times of COVID, to actually move towards home spirometry a lot. But it's important to actually do it properly, no matter where you are, to do the maneuver as close to the standard as possible. Otherwise, the results will not be as meaningful. Now, why can you get wrong measurements? Let's just dwell on that for a second. So, first of all, the most common thing is that sometimes patients do not understand the procedure very well. And it's really important to get good measurements because you'll see later on in the video, you can actually gauge a lot of information from the spirometry, even if it's a simple test. But sometimes you may misunderstand the procedure. You may not know how to blow into the machine according to what the machine is saying. So you may not be able to get a good measurement at all. Then poor communication, obviously, if the person who's guiding you through the spirometry procedure is not explaining things properly, you will not be able to do it right. So you need to have a good relation with the person who is actually guiding you through the procedure. Sometimes most patients struggle with this. You have to put a lot of effort into it. You have to blow as hard as you can. So that can be sometimes tricky for some patients who are worried. They may be a little bit embarrassed sometimes to do it. They may be and I think embarrassment is a big one because imagine you are in a lung function lab or you're in a clinic. There may be other people around you and you have to blow as hard as you can until you're going red in the face. So that can be a little bit embarrassing for some patients. It can be a little bit unpleasant sometimes especially if you're not feeling really well to do it. But that can actually lead to an erroneous result, a wrong result. There may be a bit of an air leak. So for example, if your nose clip is not on, or sometimes maybe it's not a nose clip, but maybe you are biting on the mouthpiece, but you're not really getting a good seal around your lips. Some air may escape, not be measured. So that leads to wrong results. Many patients sometimes put their tongue in the mouthpiece, which is wrong. So the tongue should be out of the way. So that's one thing that's common. So these things may sound a little bit funny sometimes, but they happen in practice. And it's something that I'd like to tell you in this video because you should not feel embarrassed. If you need to do a spirometry test, just think about it as something that you need to do. People who are guiding you through this procedure have seen everything. They've seen all the problems that can happen, all the things that have gone wrong. So please, if you go for a spirometry, don't feel like this is going to be very, very bad for you. The other thing would be coughing. So sometimes patients have respiratory disease when they're doing this procedure. So they cannot do the test because they're coughing throughout the procedure. And that leads, of course, to wrong results because we're not doing the maneuver in the way it's supposed to be done. The device may malfunction or it may not be well calibrated. This is another thing that's quite important. So lung function labs, especially that do hundreds of these tests every week, they need to calibrate their machines because you can imagine if the machine is measuring 5 liters on Monday and then it shows 5.5 liters on Friday, it's probably not good because patient care might be affected because of wrong measurements. And then obviously, if you are doing a spirometry when you are feeling unwell, for example, when you have a chest infection or you are feeling unwell or extremely tired, you may not get the best effort possible. You might not be able to actually get the correct lung function for your case. Your baseline lung function may actually be higher than what you are getting during an active chest infection, for example. So normally, it's recommended to leave about 1 to 2 months after a chest infection has resolved in order to assess the baseline lung function. However, sometimes this can vary. So the indications for spirometry can be very great. Sometimes doctors may use spirometry to check whether you are actually recovering from a chest problem. So it depends a lot. It's a simple test to measure lung function. Now, let's move on to something else. What measurements are most important? And this is where I'm getting a little bit technical in this video. So please pause it, take a breather, take a cup of coffee, take a sandwich if you want to watch the rest. This is where I'm going to get a little bit more in depth regarding the measurements you might be seeing on that report that's spit out by the machine, because those numbers are important and it can get very, very confusing for a patient to read those numbers. These are the main things that we look at. There are a lot of things that you will see on the printout, but most doctors will just look at these because these 3 things can be enough to actually give us a lot of information, as you'll see in the examples that I'm going to discuss now. So what are these acronyms? They look very weird, but you will actually see them on lung function reports. So let's go through them in this sort of graph that I found on the internet. So basically, ignore the healthy bit. I'll just move this out of the way. So FVC, FEV1, right? And then you can see on this graph that there's a volume in liters and a time in seconds. So we'll discuss about liters versus percentages in just a second, because these are reported in both ways. You will get a report of a volume in liters, and then next to it, you'll have a percentage, and that can be very confusing. I'll explain all that in a second. Now, you can imagine, when you are doing a spirometry, I'll try and demonstrate how basically we are doing a spirometry test. So bear with me, I don't have a spirometer with me, but I will show you with this pen, right? So imagine this is the mouthpiece. Imagine I have a nose clip. So I'm going to be breathing normally with the mouthpiece in, and then at some point, the technician will instruct me to breathe in as much as I can, stretch my lungs, fill them with air, and then blow as quickly, as fast as I can, and keep squeezing, keep blowing until there's no more air coming out. At that point, I will just do the opposite. I'll just breathe in again to the max. So basically, it will look something like this. I will just sort of demonstrate. So breathing normally and then taking a deep breath in, blowing, squeeze, and then deep breath in again. And then I'll explain what this graph means. So it goes a bit like this. So breathing normally. So this was a little bit strange. Let me show you that again. I'm sorry for being a little bit of a clown on camera, but I think it's important to see that it's not as embarrassing. So if I can do it as a doctor, I'm sure you can do it as a patient. So let me put the big screen so you can actually see it better. So let's use this. This looks more like a mouthpiece. So I'm breathing normally, and then at some point I have to breathe in deeply, forcefully, fill my lungs with air, blow out, squeeze until there's nothing coming out, and then sort of breathe in again. So let's do it again. So I'm breathing normally. Right, so that's spirometry. It looks something like that. Now, if you imagine that I had a spirometer and a nose clip, and I was looking just like this man in this image. Let me just put it again. So that's what I would be doing. That's what this man would be doing. Now let's go back to where we were. So this FEV1, FVC, FEV1 to FVC ratio. So this means forced expiratory volume in 1 second. This one means forced vital capacity. Let's explain that. What does this mean? So, ignore the healthy. On this graph, you can see the time. So you may have noticed that it took a while for me to breathe out all the air in my lungs. Now, you can imagine that as I'm starting to breathe out, so I've stretched my lungs, I filled them with air, and I start to blow out. So I have a maximum amount of air, a maximum volume of air in my lungs. And as I start to breathe out, that volume comes out. And in the first second, the air usually comes out very quickly because I have a lot of air to breathe out. But as I'm going towards the bottom of my breath, let's say, I need to really squeeze all the air out. That's when it becomes really difficult. So at the beginning, the flow is very quick. So I'm breathing out a lot of liters of air in the first second. So that's the forced expiratory volume in 1 second. So in 1 second, I'm blowing out all these liters. And then towards the end, as time passes, as more and more seconds pass, as I'm breathing, squeezing out all the air, the rate of flow, how quickly I'm taking the air out, starts to go down. So I'm breathing the air out slower and slower and slower. So the last part of the test, which is actually the most difficult when you're squeezing everything out, that's when you're only taking out small amounts of air at a time, sort of slowly squeezing everything out. And when you reach the point of plateau, when no more flow is detected, when nothing else is coming out, that's when you reach this sort of forced vital capacity. And that's basically means the full volume of air that you can move. That's what the forced vital capacity is. Now, normally it's the vital capacity is that sort of volume, but forced, we use this F here because basically it's a forced maneuver. That's the only thing. So forced vital capacity is the forced amount of air you can actually mobilize from maximum to minimum. So imagine this is the bottom of your breath, this is the top of your breath. All that air that you can move out, that's the vital capacity. If you do it as a forced maneuver, that's the FVC. Now, FEV1, again, forced expiratory volume in 1 second. So imagine if you're breathing out forcefully, how much can you get out in that first second? Boom. Most people normally get at least 70% of the air out in the first second. And then that just leaves this final bit of air that needs to be really squeezed out slowly. So these are these two values that we measure on the spirometry. And I think it's important to explain it in this way, because then we get to this ratio. So this is basically the ratio between the total volume. So the bottom number, the FVC, is the total volume of air. The FEV1 is the volume of air that we can get out in the first second. And this is where the ratio comes in. Moving on, you will see on spirometry reports that we get reports in liters and percentages. And this can get very, very confusing. Now, this is where I will have to just mention that the percentages are a percent of a predicted value. These will differ from person to person. When you first go in for a spirometry, the technician, the physician, the nurse who is doing the test will measure your height, probably your weight as well. They will note your age, your sex, and your ethnicity. Because most equations that predict what this percentage will be for in your case are based on these sort of parameters. And for each person, it's a little bit different. And you can imagine that these sort of percentages of the predicted value have been derived from large populational studies, from many, many people who have performed spirometry. We've measured how many liters they blow out, and they were healthy. So we know that in a, for example, healthy 55-year-old woman who is, let's say, Caucasian, they will need to be blowing out a specific amount of air in the first second or the total forced vital capacity. So this is why we have both, and we need both because it can vary. Like I said, that liter, the amount of liters for two different people may be completely different, but they may both be normal based on their height, age, sex, ethnicity. So this is very, very important to understand, and it will help clarify things a lot more when you're reading a spirometry report. Now, I'm getting a little bit technical here, and I appreciate that. If you're a patient, I hope you're still following this. But examples are coming, which I hope will clarify this. But just to summarize, when we get a spirometry report, for these parameters, we will get a value in both liters, and under parentheses, in brackets, you will have a percentage. The percentage just means how much that measured value in liters represent from a predicted ideal value. That's it. That's all it means. So let's go further down. Liters and percentages. Right. Normal becomes a bit complicated. This is where I wanted to come to, because most patients ask me, what's a good value on a spirometry? And it depends from person to person. It depends from case to case. It depends what we're looking for. Normally, for FEV1 and FVC, for the forced expiratory volume in the first second and the forced vital capacity, generally a value that looks like it's over 80% of its predicted value, it's probably okay. But this becomes a little bit tricky, and I'll show you in a second. And normally this ratio is also very important. Can we get the air out of the lungs fast enough? If we can get more than 70% of the air out in the first second, it's probably a normal ratio. These are things that are mentioned in international guidelines. It's something that's been worked out based on various studies. But everyone is different. These predicted values, the percentages, apply for a large number of people, but there may always be exceptions. You may always have someone with a supranormal lung function, where they may have 130% of predicted, and it may be normal. That may be also pathological. It may be a condition, such as emphysema, that artificially it looks like they have a very high vital capacity. It depends. It depends a lot. So normal is complicated because values can also go up and down. So various patients, depending on their respiratory disease, may have a spirometry that if they repeat it, say, every month, the values may be all over the place. Now, that can be due to technique, how you're actually performing the test, if you're having any trouble with the test, or it may actually be your condition going up and down, feeling better, feeling worse. It's important to look at the trend over time. So this is what I always say to my patients. If you have spirometry reports, keep them. They're very important over time. If you, for example, have done spirometry as part of your job, for example, because you work in a mine, for example, and you have to do spirometry every year, it's important to keep copies of that. Because, for example, 20 years later, if you do another spirometry and the values are much lower than what you used to get, then that may be the symptom, the feature of respiratory disease progressing. So it's important to keep these, to know the trend over time. I'll show you some examples in a second. Then it's important why we are doing the spirometry. What's the chest problem? Are we looking for asthma? Are we trying to monitor asthma? Are we trying to monitor lung fibrosis? So scarring of the lungs that potentially is progressive and it's getting worse over time. It depends what we're looking for. But if we know the answers to these questions, we can actually use spirometry in a very efficient way. And I think that's really important to understand. And then when are we doing the spirometry is also very important, because like I mentioned before, if we're doing spirometry when you're feeling really bad, you've just come out of hospital with a pneumonia and we do a spirometry, it will probably be at normal for most people. But then 2 months later, it may be back to normal completely, back to the baseline. So these things are very, very important when we're trying to figure out what spirometry means. And I'm sorry this video is already very long, but I think it's quite important to understand what's going on. Let's talk about why normal is tricky. Normal and versus abnormal. So I'm going to give you the example of George and Miriam. So George, let's say he's 23 years old, and these are his values. This is what we get from the spirometry report. His FEV1 is 2.5 liters, which is 81% of his predicted value. His FVC, his forced vital capacity, is 2.84 liters. So that's 85% of his total predicted value. Just to remind you, so this is the forced expiratory volume in 1 second. So that's how much air George can get out in the first second. When he's stretched out his lungs, he's blowing out the air. In the first second, he got out basically 88% of this value, right? This is the forced vital capacity, is the total amount of air in the lungs. So this value over this value yields 0.88. So these are all normal. So in this case, George, despite not having 100%, is normal. This is a normal spirometry. Miriam, on the other hand, is also normal, but her measurements, even though they are the same as George's, her predicted values are different. So Miriam, even if she's blowing out 2.5 liters, which is the same as George, for her, this means that she's actually done much better than George, because this percentage is a predicted, this is the percent of the predicted value. So her value was probably less than 2.5. So potentially for her, it would have been maybe 2.3, 2.2 liters. That's what we would have expected Miriam to blow out, but she's done better. So this is what we call generally a supranormal lung function. So something that's a little bit better than expected, but it's still normal. So this is just to show you that the liters may be the same, but the percentages may differ, and it may all still be normal. It's a spectrum. It's not something that fits every person differently. George may be, because he's young and he is a male, he may have different predicted values. Miriam, because she's slightly older and female, she may have different predicted values. I didn't put the heights here, but the heights may be different. The ethnicities may be different. So all these things matter. Let me show you now the importance of the trend. So you may think that both George and Miriam are normal. You may think that, okay, Miriam, because she's got 110%, she's doing much better than George. She's 65, her spirometry is top of the line, right? Over 100%, she's doing great. George, he's barely scratching 80%. He's not doing too well. You may think, oh, he's really unhealthy. But then we're following the trend. We're following these two people over time. And we're doing spirometry maybe every, say, 6 months or so. So we've done a spirometry on both George and Miriam in April 2022. This is a hypothetical example. And we're looking at the forced vital capacity. This is the total amount of air that they can move out. So they breathe in deeply, they blow out, squeeze all the air out. This is the forced vital capacity. Now, in April 2020, for George, this is 2.84. For him, this is 85%. So I'm just using basically these values. They start off from there. Miriam is the same. She starts off at 2.84, but for her, it's 115%. So this is where we start. And we're thinking, okay, at this stage, maybe Miriam is doing better. 6 months later, roughly, November 2020, we repeat the spirometry. They come for a follow-up appointment. They do the spirometry again. In this case, George's FVC has changed a little bit because it can change. These values can change from 2.84 to 2.78. Things can go up and down around 5%, 5 to 10% even. In anyone who is absolutely normal, we can have these variations from one measurement to the other. So he's now 2.78 liters, which yields 83% in his case, which is still within the normal range, hasn't changed that much. But what happened in Miriam's case? Her FVC actually dropped from 2.84 liters to 2.42 liters. So she's lost, right, 420 milliliters of volume. So you can imagine that volume that was maybe this much, now is a little bit like this. She can only move this much air now. But if you look at the percentage, it's 98%. It may seem that she's doing much better than George. But if you look at the trend, over 6 months, she's actually lost quite a bit. She's come down from 115 to 98%. So as a doctor at this point, I would be worried. More about Miriam, even though her percentage is higher. So I think this is really important. I think this is key. And I hope you've watched so far to understand why I think this is really important. So then they come for another follow-up. This is 1 year after their initial spirometry. George, 2.8, 2.84, 2.78. He's hovering around the same value. So his spirometry may go up, may go down, may go up, may go down, but it stays around the same value. 84%, 85, 83, 84. So he's stable at this stage. Miriam, we check her lung function again. This time, 2.11. So she has lost 0.73 liters, 730 milliliters. So that's a very big drop in a year. And now her percent predicted is the same as George's. But look how much she's lost. So she has lost 30% in absolute value, 30 percentage points. So she would feel this drop. So Miriam at this stage might be feeling much worse than George, even though their percentages are the same. And I think this is where I wanted to just show you why trends in spirometry are important and why you should be keeping notes of these results over time. Because in this case, you can see that even if the percentages are normal for both of them at all the time points when we've measured the spirometry at all these dates, Miriam is doing much worse. And this is completely abnormal to have such a big drop, especially if the spirometry has been done correctly. This is really abnormal. Let's move on. More examples. What is an obstructive pattern on the spirometry? This is again getting very technical, but I think even if you're a patient, you can probably follow what I've explained so far. So Paul, he's 58 years old. He smoked 20 cigarettes a day for the last 40 years. He started smoking at age 18. Let's go like this, hypothetically. So these are his values. He's done a spirometry, he's done a checkup with his doctor, and this is what we've seen. The FEV1 is 2.48 liters, let's say, which for him would yield 83%. This is 83% of what we would expect for Paul at this age. The FVC, 3.82 liters, which would be 95% of what we would expect for Paul. So these might trick you and tell you that this is a normal spirometry because everything's above 80%. But it's not normal because the ratio, if we put 2.48 over 3.82, we get a ratio of these two values of 0.65, which is a little bit low. So this ratio just means that if you imagine that the maximum volume of air is this, when Paul is blowing out in the first second, he can only get out 65% of that total volume in the first second. And that's abnormal. That's what we call an obstructive pattern. It means that there's some kind of a blockage and he cannot get that air out as fast as we would expect. So this ratio is an obstructive ratio, even though these values are normal in themselves. The percentages are different. So for FEV1 and for FVC, for both of these values, the percentages are calculated independently. So these can be perfectly normal within the normal range, but the ratio can be obstructive. So this is something that catches people by surprise. And Paul was recently diagnosed with COPD. Because in COPD, chronic obstructive pulmonary disease, I have some videos on my channel about what this is, but it's a condition in which basically there is this sort of blockage and people can't get the air out of their lungs as quickly as we would expect. And as they do more exercise, it tends to build up from breath to breath. And at some point they need to stop to empty their lungs of air. So this is COPD for you. Let's move on. Another example. I like these examples. Paulina. All right, so Paul and Paulina. Paulina, she is 77 years old. So she's also done a spirometry. And we see that her FEV1 is very abnormal, right? So 1.22 liters. So that's only 44% of what we would expect Paulina to blow out in the first second. She only does 44%. But her FVC, so the total volume of air in her lungs, is actually better than we would expect. Is this normal? Is this a normal situation? Look at the ratio, 0.32. So if you put this amount over this amount, it yields 0.32. Paulina has severe emphysema, right? So this is basically a condition in which is related to COPD, in which there is some destruction in the lung and there are air spaces which are widened. There's more air that fits into the lungs and people have persistently overinflated lungs. Let's just say as a simplification. And in that case, they may actually be able to fit more air into their lungs, more than we would expect. But actually, they cannot really get it out because the airways just don't work the way they should. They don't work right. So in that case, basically, Paulina, even if she breathes in more air than you would expect, in the first second, she can only get about 30% out. So you can imagine that for her, she might be struggling a lot. If she's going for a walk, if she's lifting something heavy, if she's going to do some housework, she might be struggling and be breathless at minimal exertion. So this is something that you will see in emphysema, an abnormally high total volume with a very low amount of air you can get out in the first second. So you can see that spirometry gives you a lot of information if you look at the context of the situation of that person. Let's move on. I think I have another example for you. This is a restrictive pattern. So you can see here, probably if you've heard what I've mentioned in this video so far, that this is an abnormal lung function. But look at the ratio. The ratio is normal. So what's going on here? What's happening in this situation? What can we gauge from this? So, Maria, she's 69 years old. And you might think, okay, fine. Maria doesn't have any specific medical history, but I'll tell you in a second what her condition is. So, she can blow out in the first second 1.5 liters, which represents 60% of what we would expect in her case. Her FVC, her volume of air that she can move through the spirometry in a forced maneuver, is 1.58 liters, which is again low. It's less than 80%. It's less than what we would expect in her case. But the ratio is normal. So that means that for her, in the first second, she can get almost all the air out of her lungs. There's no obstruction there at all. So she can just breathe out all the air out in the first second. But her total volume is low. Why is that? Maria has idiopathic pulmonary fibrosis. This is a condition in which the lungs become progressively scarred. And because they become hardened, they don't stretch out as much. They don't fit as much air any longer. And basically, this volume decreases over time. So it's a progressive condition. It's a very severe condition, and I need to talk about it more on my channel, and I will in future videos, because it's something I think it's very, very dramatic when it happens. And it's something that I deal with because I work as an interstitial lung disease physician. So I work in the field of pulmonology, of respiratory disease, but mostly with pulmonary fibrosis. But this, again, is something that you can intuitively gauge from the spirometry. So basically, this is what I wanted to show you in this video. I hope it wasn't too long. I mean, it was. It's already 40 minutes. If you're still here with me, thank you very much for watching. I hope this clarified some situations that you might encounter. I hope it has helped you understand a little bit better what spirometry is. And I have deliberately made this video in order to be simpler to understand by everyone. Even though you may be at the start of, for example, your career in respiratory medicine, so maybe you're a nurse, maybe you're training at the moment, maybe you're a patient and you want to understand what the values mean. I hope this has been a good clarification, a good starting point to learn more. Thank you very much for watching, and I'll see you in future videos if you come back to my channel. All the best and good health.